Hello and welcome, dear learners, to the NPTEL course on Nutritional Epidemiology, A Way Towards a Healthy Life. In the Module 2, Study Design and Epidemiological Methods for the Chapter 16, we will be studying about community trials and public health interventions. So what we will be seeing into this chapter is that the different types of community-based designs, followed by designing community trials, challenges in community trials, data analysis in community trials, and efficacy versus effectiveness. A case study discussions will also be taken ahead. So, community trials are experimental studies that evaluate interventions delivered to entire group or communities rather than to an individuals in isolation. What we usually see in studies, particularly for nutrition epidemiology, which are taken on individuals, the part is like mainly focusing on individual parameters. But in community trials, what we do experimental studies that evaluate the intervention which is focused for the group or the communities. The communities are being kept on experiments. Many health determinants such as air quality, water safety, social norms, and access to nutritional foods operate at the community level, and these are all the parameters where we can study the status of health of a community. And therefore what happens when public health intervention has to be taken, the public health intervention often needs to be delivered to group or rather than individuals. So there is a need and necessity for the groups to be taken care of, and that's the reason we take community trials on groups rather than individuals. This community trials rigorously evaluate whether there is a requirement of large-scale interventions actually, which works with epidemiologists and public health researchers. They rely more on the community trials, and they are able to make more decisions on the basis of this. These trials are especially important in nutritional program, which is very important. So if you see programs for anemia control or breastfeeding, breast promotion, and public health, these all programs, even the programs which are designed by currently Government of India for nutrition, the nutrition mission program. So these programs require community trials. Infectious disease control program, example vaccination campaigns and all those are also based on community trials. Health promotional programs as anti-smoking policies and programs related to NCD also are one which are designed to make this health promotion as a very important need. So you can understand the need and necessity of community trials. So what are the key features of community trials? We'll try to understand. On the unit of assignment, the community or a cluster is something which is being decided. Here you can see the school can be a community set or even a neighborhood or a clinic, where the community one on the first side comes with a randomization taken as a sample of an intervention group, especially for school A or school B from the neighborhood. Or through the community 2 as an sample, we can say the community group which is being seen as from school C and D. So these communities as schools, clinics or neighborhoods are randomized, and no such as an individual is being taken for this study. So we can say this is a community trial which is based on the community, and the cluster is being selected from the schools in the neighborhood, the schools in the vicinity, and also a control group is also being taken on the other part. So there are two sets of group, that is intervention group, where you will be following the interventions, you will be placing the intervention as if like we can say vitamin A as an intervention, or even we can say the medicinal part actually you are putting it for any NCD program, the intervention, and the control group where there is no such as a thing which is to be followed. On the other side, for the unit of outcome, where you can say the individual measurement or cluster analysis. At an individual basis, actually we can try to say that here there is like a blood pressure we can see for an heart patients actually, or hypertension patient, or even a weight management for a pregnant woman, or even a regular checkup for a person who is to be diagnosed, who is crossing in the mid-age actually, and taking the individual measurements to be seen. So individual measurements indicates are measured in individual within a communities, but analysis often operates at the cluster level. Why do we say that analysis operates separately? The reason is that aggregation of the cluster data which is being taken from the community and a larger group of a sample. Individual measurements are meant particularly for a person where the outcome may derive from individual to in a group of. So we can say the cluster. So individual measurements are being filtered as 1 or 2 or 3 but as an aggregate for a cluster data, it is in huge number. So you can see the parameters for this. On the third side, the focus, the prevention and health promotion. So when we talk about exercise and play, it's a sort of an health promotion, where nutrition and diet is also being seen, even promotion and we can say prevention, where you can say exposure actually for gardening, playing, and even for the part where primary focus is more on the proactive health measures and a long-term wellness across the whole community. So the outcome may also be derived with the help of the focus that is being said to be taken for the community, and where you can see age group of from children to women's, even to elderly actually, whom we can be targeting from their activities, for their nutrition, for their diet, and so a lot of other things which can be taken for the community trial. So these are all the key features where we have to see how the unit of assignment is being designed and unit of outcome and the focus is over there. So what are the types of different community based designs? So you can see majorly 5 types of community design. One is the cluster randomized trials that we can call as CRTs, and then is non-randomized controlled trials, community trials, that is called as NRCT, and then there is a third one, that is quasi-experimental design, that is QED, and the fourth one is stepped wedge design, SWD, and the last one, or the fifth one, is the cutoff design, CD. So if you take the different types of community based designs and try to understand what is the purpose actually that we have seen. In the first case, we have talked about the cluster randomized trials, and we have understood it even in the previous sections, and where we say the randomly assigning a whole community is more a purpose rather than an individual person. The reason is like we have to compare actually from the higher integral validity and can give how the randomization is really helping for the case and example which is being given in the first case for the schools and the children's actually on whom the intervention is done. In case of non-randomization community trials, where a regional pilot zone and intervention is being taken with a larger group of a sample versus a general district zone where you can say the control is being kept over there. When we try to talk about randomization is not feasible, example funding limitations might be there, or policy decisions, and so a lot of other things which may halt actually to state that non-randomization community trials, which has been found to be an unique way to see this community based design. Then comes the quasi-experimental design, where a city X, for example, or one particular city can be taken as an for intervention. The whole city can be taken rather than a group which is being stated into the cluster trials, and a city Y which is being taken as a whole city as an control, and both the city X and city Y are being matched actually. The reason is like assigning this intervention intentionally relies on a strong matching of communities, where you find a certain set of people from a particular city are controlled with a certain set of people from the other city. So this matching is very, very important, where you say quasi-experimental design, where there is an experiment which is done on the basis of comparison. Then comes the stepped wedge design, which is ethically ruling out from, for example, school 1 to school 2 and town A, the intervention based on control versus intervention based on the group of people. So exactly the start sequence and scalarity is randomized. What are the outcomes? Rolls out the intervention sequentially. So sequence is very, very important over here, and often this sort of method is being used when ethically difficult to withhold a beneficial intervention. So when you are not able to withhold a beneficial intervention, you try to rule out, and you have to go with the ethics and roll out. So you can say it is a stepped wedge design, one by one it is going ahead for a part to understand. Then comes the cutoff design, where you can say the cutoff threshold, where you can see at one level the anemia prevalence is 18%, where they receive the intervention and they work out on those and the benefits are being assigned. Where the second case, it is anemia prevalence, we can see it is 22%, where they are receiving the intervention, and in the third case the anemia prevalence is 26%, where they receive intervention. So you can see the cutoff threshold actually, where you can see it is above or it is below. So allocation based on the threshold can be seen as a prevalence criteria, and the criteria is somewhere which can define actually this type of study design. So the community based design that you have studied will give you an idea like how this randomized control trial versus the randomized non-randomized and other things are being taken ahead as. So when you are designing the community trials, what you need to do? You need to first understand the different steps. The implementation steps are very important over here, and if you do focus on the different steps starting from defining the community and unit of assignment, it is very important for a person actually to take ahead of this. When you take the community can be from your neighborhood, the community can be from school and clinics. What we need to do, we need to understand the management, the measurement part, and the large for outcomes on the small of for the management. So defining the community is very important purpose over here, and this makes more individual versus to a community, interventions versus control. The second is like intervention delivery. Like it's a very systematic framework where you have to take ahead activities like nutrition workshop, awareness, or even a school-based program, actually FNV program, where you have to focus more on telling them, inducting them, or even indicating them towards the need why this has to be taken as in stages. Mass media campaign is something which we can say nowadays has become very rampantly being used, and it has been very popular actually to state that the intervention plays a major role. Then comes for this study design, actually the processes that are being seen are more to grouped actually for randomized and the sample size. Sample size is something which takes a major role over here, where you can say one level actually you can take a cluster, and the cluster randomize and aggregated, where you can say it has been stated to be calculated on the basis of the numbers actually that you require, and the ICC effect actually after the intervention, which is making the cluster to be more seen actually to give a different sets of result. So the control group is where you have more a randomization. On the control group options actually, where you can see focusing on the D part, where the interventions for the group versus a control group, where usage care, minimal intervention and delayed rollout, which can be seen in the later part to understand how the study design really flows to give the integrated process. Okay, and finally the outcome measurement. When you talk about the population level indicators, it can be stunting, wasting, anemia, the prevalence of hypertension, even for blood glucose level, and even different sets we can be seen on the basis of a population. You can put up the indicators. Individual level you can see about a diet, which can be seen a balanced diet versus a mixed diet versus a dash diet or Mediterranean diet, physical activity, non-physical activity, no, okay, and sleeping pattern, eating patterns, it can be seen as an individual level behavior. So this is where you can see the different steps actually for implementation of community trials actually. And community trials plays these steps actually to see us like how this study design flow a major role in the randomized assignment, and there are differentiations which we can see in the intervention groups versus to an control group over here. So this way you can easily play to understand actually how with the community trials you can understand step by step the measurements versus the management part of this. Okay, after understanding this, they might encounter some sets of challenges that may come into the community trials, and if you go in understanding the different challenges, you will be able to deeply take ahead this, and you can even identify some very important solutions for this. If we talk about the contamination and diffusion as an intervention flow, you will go, there is a set which we can state that can be taken ahead for the contamination. In the challenges in the community trials, we can say if there is a intervention town where the intervention is going to be stated over here, and there is the control trial town actually, where the components of the intervention may be communities, and the components of the intervention may leak into the control communities. There is a fair chances that the participant may share information, and there might be some way actually which can be visibly seen and understood that there is an intervention leak actually. So intervention leak is something which is you have to take care, and this is a challenge which can be handled, that the media campaign are visibly everywhere, and there you can say the participants can have some sort of an information leakage. Second comes the cost and logistic, which is being seen as one among the very important challenge when the intervening at a city or a regional level compels the city infrastructure. And it shows that intervening in a particular city becomes very difficult, or sometimes intervening in a particular city becomes even easy compared to the other. So regional level requires an immense funding. So funding is something which makes more easy intervention as well as even coordination and even personal across many domains. So logistics and cost becomes a very important factor to be counted in the community trials. Then comes the cluster non-compliance, where example, schools not following the nutrition curriculum, which can be seen as something which is being as an difficulty but can be handled if you try to intervene and make it more clear about the campaigns. Okay, and not all individuals or institutions within an intervention cluster fully implement the program, which is being seen as sometimes a very difficulty to understand the non-compliance part, and you have to work on how to make it more compliant. Ethical complexity. How do you really get informed about the consent from a whole town, which is very important. For example, if you are doing a study which is based more on the purification part or adulteration part or even impurity part for a fluoride water content or in the water actually for the community that they are doing, and you are trying to take a study and how it is possible that a town representative or field collectors they can take the consent. So consent often form a political representative. Consent becomes a part which is very difficult to make it understand, and the data still need a consent because it becomes somewhere a complexity that in future if you are trying to take results of this, which may be seen as something which is individual representation that a human has to take ahead when they are taking the study. Withholding the intervention, sometimes withholding the interventions can raise concern, especially if in the early stage it becomes very important that it suggests the benefits actually when you see some sort of complexity or some ethical issues which are being raised. So the complexity may arise you actually to give this as a challenge. Then comes measurement and confounding at the community level. What does this really mean? When you have two sets of a group, a complete entire town A and a town B, and you come across a difference in the baseline economic, socio-economic, cultural, environmental, food and whole lot of social status, which confounds the result if not properly measured and controlled. So this may give a major challenge, and this can be something which can even give a major deterrent actually to your study to take ahead, and this becomes something which at a community trial level has to be thought of seriously. Attrition and population mobility. So people in the community, they are used to or they are getting for a trial sites, and when people move in and out of community, it becomes some sets of a complication which is followed by a follow-up and a longitudinal analysis. So people move in and out where a temporary migration versus for a certain set of a duration actually, which may be from days to months and even in years. So this becomes some sort of population mobility issue which can be seen as a challenge in the community trials. So on the basis of data analysis in the community trials, which becomes one important part for the outcome to be derived at an intention to treat, that is ITT at a cluster level. When you talk about an intervention assignment, which is a treatment group which you have taken, suppose a village A and a village B, where you can say regardless of the implementation, analysis are assigned. And when you try to talk about randomization benefits, that it is for a control group which is there on the other side for village C and village D, the standardized care is being allotted. So you may get a valid results over here. So intervention to treat at a cluster level are being seen defined in this data analysis. A cluster level summaries. If you talk about village X, village Z or village Y, you may talk about the summaries coming from height, weight, health score or a height, weight, health score in comparison to a particular community. So you may talk about computing this mean or a prevalence which may take average BMI, their body mass index per village, or anemia prevalence per village, or comparison of summary measures, interventions versus control. So you can understand at a community level summaries from this analysis. While versus there is an analysis of understanding adjusting for baseline differences. So what is this? Baseline measures are being seen as a pre-trial health score. And when you talk about the outcome measurement, the intervention group and the control groups are being tallied actually. So we start with from the start, and when, as you say, the measurement is being seen in comparison for the outcome for these two, and it includes the covariates into the regression modeling, where you can clearly understand the differences and the differences type approaches over here, where adjusting for baseline differences are being calculated, and which is one very important part to go through an analysis. Then comes the causal inference methods. What do we call it as a causal inference method? It is addressing the confounding when randomization is impossible. So propensity score matching, where interventions and control are being seen versus to regression, discontinuity and marginal structural model. So these are something which is very important to take ahead for a causal inference method, and this is being taken as a non-randomized community interventions. Intra-class correlation coefficient ICC, where on one part there is high ICC and a low ICC in comparison, and this quantifies the group which resemblance and the similarity, where you take one a group on high ICC as similarity within the groups, and a low ICC with a high group variation. So you can understand there is a variation being seen on the other part, and there is no variation being seen on the either part, that is high ICC. And then comes the modeling clustering effects. What is modeling clustering effects being taken as? Where the standard statistical test, you can say the t-test or chi-square test, and you may say artificially inflate significance, that are being seen as a false positive. In the advanced method, adjusting for clustering, where you have even been seen in comparison to take the multi-level mixed effect models and generalized estimating equations, where you may take the fixed effects or even random effects coming from the multi-level models, and the valid conclusion may be seen as which is being coming as an outcome for this data analysis. So after understanding this data analysis in community trials, we will take ahead the efficacy versus effectiveness community trials. Why do we need to discuss the efficacy part, and what is the effectiveness which is giving us the pragmatic trials? Explanatory trials versus pragmatic trials. Ideally, and control conditions, we take the efficacy part as an important. Efficacy part is being seen sometimes a supervised delivery, where supervised consistent implementation is being seen, and there we can say there is a high internal validity, which gives more reasons for us to discuss for the efficacy. There is a high adherence, which is being stated to have a high compliance to the protocol, and the protocol are being seen to be followed properly, followed by a strict eligibility which comes from a homogeneous group of a sample with a specific study sample, which is proving the more efficacy part. And this is being seen as sometimes a efficacy proof, which is being going towards an indication that you have a benefit over there. A smaller controlled cluster trial, focused cluster, minimal contamination, where you can say the clarity is being coming as a proven mechanism, and the policy relevance is something that a proof of mechanism that the efficacy becomes a major reason. So where you may find that there are many benefits actually which are highlighting towards a proof efficacy. Towards on the other part, when we try to talk about the effectiveness scaling, and the effectiveness scaling is being more towards the generalizability, where you can take about the sample, and the effectiveness is more a real world settings, usually practice delivery, which is integrated into the standard system, which can be an organization based or an institutional based. The variable adherence is sometimes being seen as inconsistent to average adherence, and even sometimes for aperture part, which can be coming good. But realistic variable compliance and the heterogeneous population which diverse toward the broad eligibility part, which may give a relevance to the policy, programs and planning. So community level, it is pulled up to the programs which are relevant for public and health strategy. So policy relevance, which comes with a real world impact and cost effectiveness, we can say the efficacy versus effectiveness in community trial bridges the public health research and interventions. So do we need to say that it is a proven mechanism versus an implemented world? It can be seen as something which is giving us as an institutional level and even for the scalable program to take ahead this. So we'll now come finally with to some important very case discussion that we can have. This is one very important case which we are taking it for a discussion, that is the popular, a classic example of a community trial. This is a case of 5 cities, the Stanford 5 city project. And this project was taken into cities called as California, Santa Maria, Montera, Glory and Modesta. So there were 3 cities for control that were being seen as Glory, Santa Maria and Modesta, and intervention cities were Montera and Salinas. So what are the key interventions that was pointed out? And before that, I would like to focus that the study was taken into 1978 to 1993. So you can understand the varied period from 1978 to 1993, and this was a period actually where you can say that there was no such as a community trials which used to be taken, and this was more projected towards understanding the long-term impact, the behavioral changes and the improved health outcome, and this has given a drastically good results actually that we will be pointing. The key interventions which were highlighted for this study particularly were the lifestyle education and the diet and exercise, and which was being seen particularly at that time in US, where the smoking cessation campaigns, hypertension, cholesterol control, which was being seen as an advent actually to understand a non-communicable disease, which are more projecting towards health and wellness. The outcome results were based on the findings that has come, that 36% reduction in health disease, heart disease, and this heart disease was being seen as something which was a healthy measures towards the heart conditions. There was decrease in all cause mortality, particularly for any disease condition, and this entire intervention of community trial was being taken to shape up the public health policies, which is being seen as something a very remarkable study. Then comes a study which is coming from India, particularly a revolution in neonatal survival. The study is being taken in 1990. This is being studied in a district called as Gadchiroli in Maharashtra, and this is a home-based neonatal care trial. A very classical study in India by Dr. Abhay Bang and Dr. Rani Bang, who has being seen a very pioneer in the organizations which are controlling and understanding actually for the neonatal research, infant research actually, where their organization is more based and the study findings can be reflected over here. The study background, if I have to focus, it is based in a very remote, underdeveloped tribal district of Maharashtra, that is Gadchiroli, where there is no hospital access, and the prevailing view is that neonatal care requires the hospice structure. And it is very important that when you come across such a remote place and there is a need, and how this study really focuses to give an intervention, which is being stated that there was an intervention villages, they were taken 86, and a control villages also other hand were taken 86. The intervention were more towards health education towards the mother, understanding them, explaining them about exclusive breastfeeding, their diet, their role actually, and understanding the need and necessities towards the children. Large scale trial was taken, focus on home deliveries was there, skilled birth attendants, and training of local village health workers versus VHWs and the DIAs. Innovative HBNC program, the AHA movement was being seen, and it's a revolutionary shift that a training village where the woman to diagnose and treat a neonatal condition at home, and this has been seen as a self-administration of antibiotics, that is gentamicin, and even which is projecting towards oral plus injectable antibiotics, which was being seen as somewhere the AHA, that is an innovative project actually which has seen a remarkable effect. What are the key findings of this? On the 2 sets, where we can say it shows a 62% of remarkable reduction in the neonatal mortality, which was being seen as a very productive step taken by the Search Foundation. Proven very in the complex life-saving care, and it was being taken very safely by the trained burnt attendant. Semi-literate community workers who were identified at the community, and the results were published in the very popular The Lancet in 1999, and which made something as a very great health impact. The national policies changes and the government officials started implementing this, and this was being seen as to identify the role of VHW. the village health worker, ASHA, the accredited social healthcare activist, and they integrated into the National Rural Health Mission. The NRHM got its integration and the influence of the training and the framework for national-wide ASHA model, and this has been seen as a major step into the public health intervention. What was the global adoption for the WHO and UNICEF from this and the study from India? That was the community workers like in African countries, Asian countries and various other countries started receiving health globally. They were trying to endorse by understanding this and taking the lessons by WHO and UNICEF as a core strategy for infant health globally. This has been seen as a very remarkable study in implementing in countries like Africa and Asian countries. So, in summary to this chapter, community trials are indispensable tool for public health, and as you have understood through these two case studies also how this can be taken as a major step to change the policy. The community trials allow us to evaluate systemic population level interventions that cannot be tested in a clinic and it can be done only in community. While they are logically challenging, they might be expensive and it requires a complex statistical adjustment to understand encountering clustering. They prove the most accurate picture of how a policy will actually perform in the real world, which is, you can say, a testing of a policy in the real sense. So, community trial bridge the gap between individual healthcare and a true population health. So, with this we come an end to this chapter, and these are very important references that can be taken ahead for this chapter on community health trials. Thank you.